Okay, good morning. We're going to go ahead and get started at 8:31. We're at the Healthcare Services Review Project Committee. The first thing on the agenda is roll call, please. Annette, can you take roll call?
Supervisor Canepa,
Here.
Supervisor Dean, County Administrator Regallo,
Here.
Ms. Hopkins,
Here.
Mr. Brucker,
Here.
County Council Kiernan,
Here.
Ms. Macedo,
Here.
Mr. Wilkamp,
Here.
Ms. Valentine,
Present.
Mr. Castro,
Here.
and Ms. Harlan.
Here.
And for the record, Supervisor Ding is absent. The next thing on our agenda is to approve the minutes from April 16th. And I'm not sure if everyone has had a chance to review the minutes. If there are no questions or changes, I will entertain a motion.
Motion to approve.
You could,
Second.
thank you. Motion and a second. All those in favor?
Aye.
Annette, did you catch that? Okay, thank you. And then moving on to our informational and discussion items. And first up is Dr. Dulio with Celebrating Quality Measures.
Good morning, everyone. For those that don't know who I am, I'm John DiUlio, the Chief Medical Officer for San Joaquin Health Centers. I was asked to put together a quick presentation talking about quality, a little bit about recruitment, and kind of what's next for our county healthcare system. So this first slide shows a depiction over the last 3 years of our QIP, Quality Incentive Pool Program scores. As you can see, quite a large jump year after year. And I'll highlight this. So 2021, as a system, we're about 58%. By 2022, we're at 78%, and then 2023, 88%. And then this past year, 2024, the final reporting was due about a month ago, and we were preliminarily scoring 43 out of 40 measures. The highest you can score is 100%, but with overperformance, we're currently sitting at 43 out of 40. This is projected to be linked to about $78 million for our healthcare system in our county for the year 2024. Final audit is pending for August, so next month. Just a quick caveat. You may ask, why such a large increase year after year after year? So, and these are kind of the big bullet point items of things that have been developed since 2022. So dashboards. So we've developed dashboards that tell us how we're doing as a whole, at the clinic level, and then the individual level. And the real reason for that is we can see where missed opportunities were, like I said, from the institution all the way granular to the individual level, and we can interject and lead improvement. Quality-led outreach, we're outreaching extensively on patients that are due for care gaps, so have holes in care, whether that be uncontrolled chronic disease, so hypertension, diabetes, or are due for cancer screenings, things like that. Quite a bit of pre-visit planning also by the quality department, where patients that are scheduled are coming through the schedules and identifying what the patient's due for at that visit, so it's flagged for the clinical staff. Standing orders, I'll talk about that on the next slide, and then gap clinics. So gap clinics are clinics that we develop that are just for patients that have quality care gap holes. So again, patients that maybe have chronic disease that aren't controlled, patients that are due for cancer screenings, wellness exams, we're just outreaching them and just filling the schedule just with patients that have care gaps. This is gonna be hard to see, but this is an example of the first standing order we created, which was October 2022. This is for colorectal cancer screening. And what this says is clinical staff that is trained are able to outreach patients that are due for colorectal cancer screening, counsel the patients on the importance of having this done, counsel them on what the options are, and then the patients that agree, for example, for Cologuard, they're able to put the order in our EHR, electronic health record, under the PCP's name. That kit is then mailed to the patient completes it, and then we're compliant for colorectal cancer screening. And this really kind of opened the floodgates for our standing orders. Once this worked, if you think of it, we did it, right? So it went then to mammograms, mammography, then it went to hemoglobin A1C for diabetes, et cetera, and really every measure we could address outside of the patient visit, we did via standing orders. And it's really to decrease the burden for the clinical staff. Recruitment, this is continuous. On this slide, I kind of put recent providers that just recently started or are starting shortly. So we just had an internal medicine doctor start last month, actually a graduate of San Joaquin General Hospital internal medicine residency. We have 2 family medicine physicians starting this month, one from Ohio, one from Seattle. Last month, we had 2 family nurse practitioners start. We have another that already accepted a conditional job offer and has started the onboarding process. We have 2 hybrid pediatricians starting shortly, one in August, one in November. Hybrid, what that means is these pediatricians will round in the hospital for newborn nursery, and then when they're not in the hospital, they'll work in the clinic. We have a full-time ambulatory, so just clinic pediatrician starting in August. 2 certified nurse midwives started last month to help with our OB services. We have a OBGYN that will just be in the clinic starting in October. Whoops. And then many more to come. So I'm probably conservatively doing 5 to 10 interviews a week, and this is just continuous. What's next, right? So like I said, the August audit will finalize our QIP scores, actively sharing our best practices with other FQHCs. So really the standing order model and then the gap clinic model is pretty unique to us, especially to the degree we're doing it. Biggest success is, right, this is the culture and this is embedded in what we do every day. The team's never satisfied. Even if we're scoring 90th percentile, we really want to be 100 percentile. We're not chasing metrics. We understand the outcome, right? This is outcome driven. This is patient centered. It's not just about hidden metrics, but it's really about, especially the cancer screenings, early detection, early intervention to decrease morbidity and mortality. And this isn't the goal, it's the minimum expectation for the team. Thank you. Any questions? Anything I can clarify?
So Cologuard, how effective is that?
Yeah, so when we started with Cologuard, we were the worst out of all the institutions in QIP, and as of last year, we were number 3. So drastically.
And how long did that take?
What was that?
How long did that take?
Well, we started in October of 2022. So within a year, we were already meeting the measure, and then now we're overperforming. So in about a year and a half, we went from not meeting it to overperforming.
Thank you.
There are no other questions? That's it. Thank you, Dr. Julio.
Thank you.
Next up is Genevieve Valentine with the Lodi Access Center update.
So good morning, everyone. So give you an update on the Lodi Access Center, where we are. If you do not know what that project is, I will actually give a little bit of an overview of what the goal is of the Lodi Access Center. So the Lodi Access Center is a homeless shelter. It just happens to be called an access center in the city limits of Lodi. Approximately 2 years ago, at this point, 2 years ago, the city of Lodi needed assistance in terms of how to provide better wraparound service for the homeless population in Lodi. So conversations started with the county from a healthcare services perspective. How can we assist and support? This is after the fact that the county has given approximately $11 million to date on the build of the Access Center in order to make sure that homelessness is reduced in the city limits and those around based off of residency in Lodi and North County. So what ended up happening at that point was a series of meetings with the city of Lodi, healthcare services, the CAO's office, and other partners. Up to date now, what ended up happening was in June, there was a large force of county staff that attended one of the city council meetings in Lodi to really discuss a city-county collaborative on being able to provide health services within the Access Center. This would include public health, behavioral health, the health clinics, and HSA in terms of eligibility. So we presented a model to them. This would include an additional $1.8 million to construction through HRSA grant dollars to build a health clinic within the Access Center for those that are receiving services through the health clinics. We have approximately 4,000 to 5,000 individuals who are open beneficiaries receiving services through the health clinics in Lodi itself, but we can actually expand that penetration rate by being specifically located at the Access Center, especially with our ECM and CSS services. So we are proposing to work with the city to build a access point specifically for wound care and other health services, starting with 20 hours a week, hoping to expand to 40 hours a week of services built in the Lodi Access Center. Behavioral health, in addition, is proposing to give infrastructure dollars through our bridge housing funds in order to have 8 mental health respite beds and 4 respite beds post-crisis. So a total of 12 beds at the Lodi Access Center, so we can remove people from our ERs that are just pending housing placements, so that we would be able to put eyes on them, or also be able to have quiet area for those that are mentally ill waiting for longer term housing placements. So far, so good with the city of Lodi with those pieces. We are also proposing a collaborative between the health clinics and behavioral health and public health of having our first sobering center located at the Lodi Access Center. We've already started conversations with EMS and the local fire department in Lodi to make it a piloted alternative destination in order to prepare for Be Well. So we have started a variety of moving parts. At this moment in time, the city has agreed, without anything legally in writing, to move this partnership forward. So we have 2 different contracts that are going back and forth between both legal counsel from a health clinic's perspective in terms of contract and leasing space in the building of the HRSA site, and then on the behavioral health site, in order to make sure that we can move things forward. Our ultimate goal is to have contracts in front of the Board of Supervisors in late August in order to move these processes forward, because there is very specific grant timelines on both the HRSA grant spend as well as on the behavioral health side, in order to make sure all of the funds are spent in accordance with the grants, but also to meet the needs of the Lodi Access Center. A part 2 to that is behavioral health is also working with the city to have a 40-bed transitional housing unit lease agreement, so that those that are leaving the Access Center actually has a place to go. So it's not being able to just provide services at the homeless shelter from a full wraparound holistic perspective, but there actually will be a location for those that are mentally ill or those that are struggling with substance abuse to have longer-term transitional housing. So we are trying very hard to have our own continuum. We've also started conversations with Lodi Adventists on what that would look like as well from their hospital, on how we would actually reduce those sitting in their hospital, not just our own, that are Lodi residents, in order to make sure that there is consistent workflow within the Lodi Access Center and our most underserved that are at the homeless shelter. So that is my update on the Lodi Access Center.
Quick question, so on that all got squared away with who the building is and they were gonna sublease it, so that's all been put to bed, or is that still an issue?
I will direct that to allow Quinny to answer a little bit, but I can also answer as well.
We're still working on a few things as far as cleaning up the documentation. We do need to get a new MOU because it's expiring on the 31st. Oh, okay. All right, so we are still working on some documentation, but it sounds like conceptually, we are on the same page and they understand that they're not gonna sell that building.
Okay.
And if I could add, the MOU that expires in September would be the MOU for the use of the ARPA funds for the capital. So with the agreements that are going to go, the contracts that are coming to the board in August, we will also still need another MOU to extend it to finish the.
So it's contingent then, so that ARPA money has been designated for that certain.
That's
Great.
correct. And they have to finish the project by December of 2026.
Okay.
But technically, the MOU only goes through September of 2025.
And to add to that, the city is open to allow healthcare services to participate in the writing of the RFP for the homeless operator, so who would actually operate. So in that would give us the ability to direct that there cannot be a duplication of efforts with the health clinics specifically, and the competition of ECM and CSS services, which is enhanced care, case management, and community supports, which is a benefit where you cannot have it open to more than one provider. And so the agreement will actually say whoever is the homeless operator cannot provide the same Medi-Cal services as those that are co-located. So that way we are covering our own investments by both the capital, but also if we're providing a service, we should be able to draw down that additional benefit. And so the city has agreed to have us in the discussions on the operator of the access center, which
So there
should
won't-
be going out in December. So that way we'll be complementary of each other, rather than be in competition of
And
each
then
other.
there's not duplicate billing?
Correct.
Okay.
Are there any other questions? No. Thank you, Genevieve, and moving on to Genevieve with an
think I just got all the
update,
next couple
with an
of things.
update on the Be Well campus.
So thank you, Sandy. The Be Well campus is moving and shaking. So for context, if you guys have not seen the beautiful news, the Behavioral Health Department won a $137 million grant towards the $260 million projected cost of Phase 1 of 4 buildings of the Be Well campus. We have not officially signed the contract yet for the award. We are still working out a few things with the state. On the award, the goal is that the contract for the $137 million, which the board gave delegated authority for me to sign that sometime this month. So the goal is to have the contract signed sometime in August. The state has actually said that they have until September to actually execute all of those contracts. So we are working through that. There are twice-a-week meetings now for Be Well. Some of it is planning and design. The other has now turned into 12 different subgroups, anything from sewer lines and lift stations to a variety of different things. God only knew when he was going to let me learn about sewer lines, because I had never anticipated that I was going to have to learn anything about all of that. So we are absolutely working through a few things. That we are currently over budget, and I will say that out loud as we are designing, and now we are looking at where to cut, not program, but where to cut other things. The biggest thing that we have learned in this process is that site, the 20 acres, was being used as a dump site for Public Works and GSD for dirt. And so there is a lot of dirt there that shouldn't be there. And so people were also stealing our dirt. And so we have to actually increase the site in some areas 3 feet. And so dirt has become a very interesting discussion. And the cost of actually acquiring more dirt, I would have never guessed that it was going to cost so much for that. In addition to that, parking has also become an interesting conversation on the cost of parking, which was not part of the original quote, and what that would look like. So lessons learned for when we apply for Phase 2 of the Be Well grant. What we are also looking at is with Phase 1, what would it look like to grade the entire site and to actually put sewer and electricity for all 20 acres and not just the acreage for the first phase, because it will actually be more cost effective to put it for all of the sites, not just the whole, the Phase 1. So lots of things that will be coming back for discussion with the board of how to move things forward. But we are very optimistic. There are a few other things that is coming into play tomorrow. The project is going to Planning Council for approval for Phase 1, and the final part of this will go in front of the Board of Supervisors on the 29th for approval of CDD's operational plan for planning. So more to come. What is very exciting about the Be Well campus, though, is not just the fact that this will drastically change substance abuse and mental health in our county. There are 2 very specific partnerships that are occurring. Public Health is actually planning on having approximately 1,500 square feet on the campus for a TB clinic. The TB clinic was supposed to be in Phase 2 of the public health buildings, but we realized that TB and TB testing and a whole bunch of other things is a requirement for every single service delivery at Be Well. So why not have it co-located at Be Well? So public health is putting together some plans to have about 1,500 square feet to have a TB clinic specifically at Be Well. In addition to that, we are looking at having an integrated urgent care ran by the health clinics. And what I mean by urgent care is they have agreed to actually be the MAT provider for outpatient services. So the opiate MAT provider on behalf of behavioral health, where they will be able to do both the mild to moderate, but also the moderate to severe medicated assistant treatment. That's what MAT stands for substance abuse. So it'll be a fully integrated urgent care. In addition to, after we pilot the Lodi Sobering Center, we will also actually use whatever lessons learned to have it as the Sobering Center model at Be Well. So it'll be the health clinics, behavioral health, and public health putting together the Sobering Center at Be Well as an alternative destination. We've also already had conversations with some of our ambulance providers and barely started talking with our law enforcement providers on how that will be an alternative destination so that we do not have to have those that are detoxing go to the ER at General, which is where they've been going, or over to the Sheriff's Department and getting booked. So the hope is we will be able to offload those individuals to Be Well in order to provide full services. We've also started preliminary conversations with the hospital to have them be the primary lab for those that needed certain services, and they will be our pharmacy. So all pharmacy services that are necessary won't have to necessarily go to the behavioral health 1212 pharmacy. Whatever could be done at our local hospital pharmacy, it'll be done there. So this is definitely a healthcare service, all agency collaborative for the Be Well project.
Thank you. Are there any questions or comments? Right? No. Okay, seeing none, we will have one more presentation from Genevieve on the CAO Healthcare Services Oversight and County Alignment Efforts for the clinics.
Last time you guys are gonna have to hear from me. And Miss Brandy, please jump in if I miss anything. So in April, the Board of Supervisors approved for the health clinics operation through the co-applicant agreement to be in alignment with healthcare services at large. So budget oversight, HR oversight, procurement, any and all administrative supportive services, the health clinics are now under the purview of healthcare service agency at large. And so what we have been doing, in addition to educating the SJ Health Clinics board and their staff, is really doing a deep dive in all things that have not been in county alignment for the health clinics. We've started with HR specifically, including their locum contracts, their employment contracts, and so forth. We also are doing a look at all of their IT and how to align their information technology under healthcare services, since we do have our own chief information officers for healthcare services. We also are looking at leases and buildings and what that would look like from an infrastructure perspective and how to co-locate. We're also looking at all things procurement. So thank you, Concepcion and Purchasing Department, with being there patient with us as we are working through all of those things. We are also very much looking at a centralization of all things HR related. So making sure that evaluations are the same in public health as it is in the health clinics, as it is in behavioral health and OME. So we are definitely doing an alignment of services, but also a centralization. So as we are bringing in the health clinics into the agency, we are looking at where there are gaps of consistencies and duplication of efforts of healthcare services at large. So this is not just an alignment of the health clinics, but we're using this as an opportunity to look at how healthcare services as an agency is functioning and really setting up a model that may take us a little while, but setting up a model where the agency is really supporting all 9 subdivisions of healthcare services to make sure that we are being both cost effective but client-centered from a holistic perspective. So we are matrixing it, we are looking at it, we are looking at outcomes. Healthcare service leaders have descended upon the health clinics. There is someone there every single day during the week. Matt Garber has been approved by the Health Clinics Board to be the interim CEO as we are actively recruiting and walking alongside Dr. DeLeo on all efforts that need to be put into play. And really looking at this as the health clinics is just one part of health that is in the continuum of healthcare services. So I don't know, Brandy, if I missed anything or if there's any additional questions.
I
or-
don't think you missed anything. I know our office really appreciates the team jumping in and helping out, and with the unexpected departure of the interim CEO, project director, just really providing consistent leadership. I know different leaders from the clinics have mentioned to me how much they appreciate the support.
Thank you. We're trying awfully hard. Dr. D, did I miss anything that you want to add?
Does anyone want to add anything or have any questions?
No, I just want to echo what was already said, right? So I think that all the efforts are noticed throughout the staff from top to bottom, especially with Genevieve's point, right? And Brandy's point that there's been someone every day at the administrative building, whether that be Adam, Kara, Matt, et cetera.
Thank you.
And I do want to thank Adam and Brandy for jumping in as well, needing that additional assistance from the CEO's office as I'm muddling through things that I've learned a lot since being in the healthcare services interim role and permanent role that I never encountered before. So their grace with me has been wonderful, and Quinny keeping me in line as well.
Thank you. So that's it for our informational items. And Annette, we're up to the public comment. Are there any public comments?
There's no public comment.
Thank you. So any comments from the committee?
I have one because I didn't unmic fast enough during the first presentation. Dr. Dulio, will you go back to the 4340 slide? The scores. Thank you. I just wanted to take a minute because I think we went through this really quickly, but I wanted to thank both the hospital and the clinics for all of their hard work over the last couple years to really raise those QIP scores from places where we were underperforming to where now you heard during the presentation today that we're actually overperforming. As Rick told me, we don't get credit for 107%, but we pretend we do. So I just did want to pause for a minute because I think as an organization, as a county, we work really hard all of the time and we work really fast when we identify opportunities and things we need to work on to stop and celebrate and thank the team for all of their hard work. So thank you.
I'll
Thank
agree with that. I mean, the Lodi Access Center, that's, amazing work. To get everybody, we always talk about doing this, and I've seen it for 2.5 years, and sometimes, like you said, the speed of government is not as speedy as I would like to see. But we're getting there, and I think it's collaboration, and it's not as contentious in here as it was when I first started. Not looking at anybody or anything. We're moving forward. And I've seen it. Yeah, we've seen it. And we see, you got to look in the mirror every once in a while, and what you see is not always the prettiest thing. So, changing that image is. So, but I think, at least we're making progress, in the right direction. I know it's difficult, and it's like you said, the stuff that you learned, the stuff that I've learned has made me obviously a better person and a better leader, but at the same time, it's hard because getting things to actually change and the employment and the struggles of hiring folks and getting qualified folks and, and that's the face of our organization. So how do we do a better job? I know it doesn't happen overnight, but it's all of everybody working collaboratively together, which is getting us closer to where we need to be. So thank you all for doing it and being here. Do we look at deep dives? And because basically, like you're saying, it's quality care for the patients that live in our county. And sometimes the egos get in the way and people's personalities, and I think that's finally getting pushed to the side, and we're putting people and patients first, and I think that's the most important thing. So thank you for collaborating and coordinating and at least, bring in the questions or the concerns. Hey, we have this concern, we're trying to address this. And that's all we can ask, right? Just do your job and do it well. And I think everyone's doing that, so thank you.
And I think Rick and I are trying our darndest to co-parent together and make sure that our healthcare agency system at large is complementary of each other. And I think what Rick and I can do a darned good job together and playing that back and forth pull of what's needed at the hospital, what's needed in other departments and agencies. So Rick, thank you for being my co-parent with me.
Thank you as well. I think your leadership has been probably the lightning rod that has helped us get to a better spot. We do have opportunities that we need to continue to pursue, especially with the challenges that we're gonna have going forward with Medicaid and, the direct effect, I think, immediately on the clinics in regards to the status of the non-legals that will no longer be covered. So there's challenges ahead. I still think there's opportunity on the expense. I think we should look at everything expense-wise and say, is this a duplication? And if it is, let's not duplicate. And it doesn't matter where that process ends up, whether if it's better in public health, do it in public health. If it's better in the clinics, do it in the clinics. And if it's better in the hospital, do it in the hospital. But just don't do it 3 times.
And I think one good example of that is we're even talking about medical records. Like, we're starting at, even at that level of why are we duplicating some of the efforts from a medical record perspective? Why not centralize medical records within the hospital, who's the holder of all of those things? So thinking completely and utterly outside the box, not just lab services or street medicine from a structural perspective. So I really appreciate the hospital even willing to have some really random conversations and questions of where does medical records housed and who has that oversight? So I just want to appreciate the hospital and their creative way of thinking.
Thank you. Very good comments. And I would like to also say thank you to both of you, because I think with your leadership, we have come a long way. And just to bring in everyone as far as healthcare clinics and everyone working together, and to see where we can cut costs, like you said, maybe not cutting services or programs that we really need for the public, but certainly cutting costs. And I think it starts with the leadership and being able to work together. So I really appreciate you all. Thank you. Any other comments? Okay, moving on. I'm sorry, my throat. Moving on to closed session. There are no closed session items scheduled for today, so we can adjourn at 9:03. Our next meeting is on October 15th. Thank you.
Thank you.
you